Kia ora everybody, my name's Dan Exeter. I am kind of a very dislocated geographer. I am trained in geography, I make maps for a living, but I'm based here in the School of Population Health in the section of epidemiology. And while I'm fronting this presentation today, I have to give a shout out to my team, Jinfeng Zhao, who's a GIS expert and behind the data zone creation, Michael Brown on the grant application as a research assistant, but so much more. He's the data wrangler, he's the customer service negotiator with different organisations, checking fit for purpose things. Aria is our biostatistician. Sue Kringle, many of you will know, is our Māori GP, public health specialist, social barometer in many cases. She'll just go, Dan, what the hell are you doing with that indicator? So that was my test as well. And another shout out to Nicola here, who has been using the IMD, has been a very big proponent of its outputs, and some of the work that I'll be presenting is some of the work that she's been doing as well. The data that I am presenting does include data from the integrated data infrastructure, so here's the obligatory data disclaimer statement, which is recognising that these aren't official statistics, but they are work of me and my team, and those views are my own rather than the universities or Statistics New Zealand. There is a big shout out to many people. It's a very big team. A few people have been here just doing a couple of jobs, but also to people like Val May, who was at the time working for Inland Revenue, or experts in education and so forth. Far more useful than reading a data dictionary. So today I'm going to be talking about what is deprivation and how it's measured at the moment in New Zealand. Quickly talking about how the IMD could be used to tackle inequities. The big question, how is the IMD different to NZIMD? So what is deprivation? By and large, we use it as a proxy measure for individual socioeconomic status because we don't have information about individuals. That's changing with the IDI. Historically, deprivation has been referred to as a state of demonstrable disadvantage, and it's a relative indicator. It's what my neighbourhood is relative to those around me. So in its nature, there will always be the 10% most deprived or the 1% most deprived, and equally the 1% least deprived. In Townsend's paper, he was referring to something along the lines of deprivation to say that it should be applied to conditions and quality of life where there's a lower standard of living, and he refers to what is ordinary in a particular society. And this kind of follows on quite nicely, I think, from Andrew's last statement. What is ordinary? What is ordinary for whom? And very much, I'm going to follow a tradition here, I apologise to Andrew, which is still Eurocentric in many of its definitions. So, and the key difference here is that it's area measure of deprivation rather than living in poverty, which is referring to the lack of income. NZIMD is universally used in research and policy and advocacy in New Zealand, and it has been since it was launched in the late 1990s. It's a census-based indicator, 9 census variables. It's awesome. It can be linked into health and social data retrospectively. It ranks areas or communities into deprivation scores, into least to most. And these are strongly and very consistently associated with the social gradient. It's also available at 2 different geographic scales. And so at the same time, it's, you know, in the age of big data, and don't get me wrong, NZIMD was, you know, a game changer in New Zealand society, and this is the next generation, if you like. One of the limitations that I've always had with NZIMD is that when we look at a map like this, we can't actually ask the question, well, what's happening in Tairāwhiti? It's bright red on the map. It's one of the 10% most deprived, or 20% most deprived areas. Ironically, it's the same as Northland, and this is from 2013, and it could have been 1991 or 2006. The pattern's broadly the same. What I want to know is, in Tairāwhiti, what are the drivers of deprivation and how are they different to different places? If we zoom in again, we can see again this is Auckland Airport, where our international guests arrive. Part of South Auckland, bright red. Part of West Auckland, also bright red. What are those drivers? And in terms of policy, if we've got a limited budget based on our government funding sources, how are we going to target the things that matter to improve the health and well-being of the populations that you're wanting to serve? So I took a different approach, which was based largely on some research that's been done in the UK, and this has been in the UK for about 20 years. It leverages big data. It leverages the ability to customize zones to a level of statistical robustness, which is a problem. And one of the other things that I was really, really interested in trying to do is trying to unpack those drivers of deprivation and consider different domains of deprivation and how they feed into the overall picture. So we have 7 different domains of deprivation, which all combine to create the IMD, the Index of Multiple Deprivation. Employment measures things like the population who are working age who are excluded from employment. Whereas income is historically, in the IMDs in the UK, is about the number of people in a neighbourhood who are receiving an income-related benefit. With some guidance from MSD and Inland Revenue, we worked with Valme and we calculated how much money was spent by those 2 organisations in a data zone so that we could get the variability on a house-by-house basis of how much people are earning or receiving from the Working for Families. Unlike NZIMD, which didn't include crime data, we've also got a crime domain and a health domain. And in terms of crime, we're looking at the 7 major offences, again guided by some input from the New Zealand Police data specialists. The housing domain is about household overcrowding and people living in rented accommodation. We looked at all kinds of different things when we were brainstorming for the indicators that were relevant to our topic. How many houses built before 2000 actually took up that insulation subsidy that we were entitled to? Nobody had that information in a central locatable source that we could geocode to map. The health domain really looks at the population with high level of ill health. Education is about youth achievement, and again this is youth achievement at leaving school before they were 17 years old or without level 2 NCEA, but it also includes pathways to tertiary, those who are not in employment, education or training, and the whole population or the working age population. And we also have a measure of access, which is the distance to, or the median distance for the 3 closest types of facilities. So if we're interested in supermarkets, how far do I have to travel in my neighbourhood to go to these different sources? But we needed a geographical base to do our analysis. And the slides that Andrew showed about census area units or mesh blocks is really, really useful. For this case, it was really a case of Goldilocks in the 3 geographies. Mesh blocks, they're great. They've got 100 people or so. You can find out something about people. But in the IDI, we have suppression rules so that if the cell size is fewer than 5, so there's 5 people aged over 65 living in my particular community, that data would be suppressed because I'd be able to go, oh, that's Jack and Margaret, that's Heather's mum and dad, right? So in order to reduce that, we needed to go up to the other level. Census areas are effectively suburbs. So what variability do we see in a census mesh block, a census area unit like Mount Eden or your own local suburb? You all know that there's a particular street that you might not go down because it's, you know, the more deprived neighbourhood, or you won't let your kids go and play in a park in a particular part of town. So we created data zones, and these are the red boundaries here, the black thin outlines are the census mesh blocks, and they were designed to have a reasonably consistent population, minimum of 500, ideally between 500 and 1,000. There's a few outliers. We didn't think it was a good idea to bring Stewart Island into the mainland to reach that 500 population threshold. And equally, there's some mesh blocks that have got 1,800 or more people living in a particular mesh block, so we kept that as its own. Why did we do it? Well, the suppression was part of that problem, and in this case, the top plot, the top map, is for the population aged over 65 years from the 2013 census. Across the whole of the country, there are 16 data zones that have been suppressed, and so there's no information for those 16 data zones. Compare that to nearly 19% of census mesh blocks and 7% of census area units. The bottom plot represents the population who are Māori according to the 2013 census, and only 4 data zones have been suppressed. Again, compared that to 13% of census mesh blocks. What is the impact of reducing your population sample by 13% when you want to target Māori to improve their health and well-being and identify areas of risk or intervention locations when 13% of your population have been excluded systematically by rules that are in place to protect their confidentiality and their identity? We're very grateful to Inland Revenue, MSD, Ministry of Health, Stats New Zealand in various forms, New Zealand Police, Education, the College of GPs, LINZ and other organisations who provided the data that we used for our measures. We were specially targeting domains of deprivation, and we were trying to identify indicators that were really specific to those domains of deprivation. We didn't really want something like if it wasn't specifically related to unemployment then or employment, we'd have to think, well, whereabouts do we place it? We were trying to be as direct as possible. We wanted to make sure that it measured that specific form of deprivation and that it could be updatable and was preferably already updated. We needed those data to be statistically robust, and we weren't really interested in the 1%. We needed it to be generic as much as possible so that we weren't simply showing we're the 1% of the population who don't have access to broadband. We wanted to look at something that was a more random event, if you like, than being specifically clustered in parts of the country. We looked at, as I said, hundreds or dozens of indicators, but we ended up with 28 criteria, and I know that this plot is going to be too hard to see. One of the key things to note is that of the 5,958 data zones which we have for the whole country, each one of the domains has a ranking. So we could look at a question of what's the association between cardiovascular disease and deprivation. We could either look at it using one of these domains like income or employment or housing, or we could look at it for the overall index, and we'll come to that in a moment. Each one of these pillars is weighted slightly differently based on the theoretical ability for the data to explain or be associated with particular aspects of deprivation, and also to represent the data quality. So where access to services or access to basic utilities might be a really, really strong predictor of deprivation, in this case it's really about urban-rural differences. And if you're a geography student, it's probably very consistent with the Burgess model of concentric circles from the core, where everything's available in the CBD. As you go out from the CBD, out to the peninsulas, things will become less and less able to be accessed. This is the pattern of the IMD for Auckland City at the data zone level. In these maps, bright purple represents the 20% most deprived areas in the whole country, where the light blue represents the least deprived 20%. This is what the NZIMD looks like, and generally there's a 92% correlation for those who are interested in stats. But really, what we show here is that when we look at the IMD rank for those 5,900 or so data zones, increasing deprivation from left to right, NZIMD on the y-axis. These areas, these are places that NZIMD ranks very deprived, but in the IMD much less so. This is largely driven by housing, the two housing variables in NZIMD, which are given roughly equal weighting in the NZIMD. By contrast, the housing domain only accounts for 9% of the overall IMD, where it's about, I can't remember, it's about 30% or something of the NZIMD. And these are largely restricted to places like Island Fields and Christchurch, or the Dunedin student flatting area, where you have lots of people living in crowded conditions or renting. But by and large, students are generally fit and healthy people who tend not to tick the boxes in the other 28 indicators. At the other end of the extreme, these are largely driven where we've got the health or the crime or other indicators that NZIMD doesn't contain. I mentioned about using health in the domains, but health has got to be one of the biggest users of a deprivation index, certainly in New Zealand. And so when we developed the IMD, we took one of the domains out and rebased the weighting so that if you're interested in looking at something like respiratory disease, which is one of the items in the IMD, in the health domain, you can take out the health domain and still look at an overall pattern with the other 6 deprivation domains combined. And you still get a very consistent pattern. That's with the IMD and that's without the health domain, so very similar. This also gives you an idea of the drivers. I've only shown you the map for the Auckland DHB for the IMD. But if we zoom in and look at the different components, you can see that things like crime and housing are very important determinants in terms of the Auckland DHB pattern, but it could be something else, like maybe it's health and education in Hamilton or in Tairāwhiti. It's a graphic equaliser plot which shows that different variation across different DHBs. Comparing Northland and counties on the top row, you can see that overall they have about 25% of their areas among the most deprived overall, but they have very different patterns when you break it down by the IMD. We have a website that's got a lot of information linking the 2013 census data. You can get shapefiles if you're a GIS analyst. You can get Excel files to create, to link in. And really, we can explore the drivers of deprivation using interactive atlases, looking at those drivers. We've generated different reports for geographic regions, so you can create a selected area, create a profile. We've got another map, which is interactive, that allows you to do what they call a situation analysis. So my colleagues from Alcohol Health Watch have been using this kind of map to say, okay, there's a liquor licensing application at the moment, and we know which address it is. What's the demography of that place? What's the deprivation circumstances in those places? Back in March, there was a case down in Takanini, and they showed that the area that they wanted to add the additional liquor outlet, which would have been the 5th in the community, was the 10th most income deprived place in the country, and as a result, that application was withdrawn. So a community win in terms of advocacy. You can geocode data. If you're doing surveys, you can just integrate, enter your address, it returns a data zone, so the information isn't kept about where you live, but it's your neighbourhood of choice. And embedded into that, when you click finish for the survey, all of the IMD and information is attached. This is some work that Nicola did with me, using before school check and linking the data with the census. And what this shows is at 4 years old, based on the screening, the lip screening for dental caries, what is the probability that a child living in a deprived neighbourhood of different deciles is likely to have some form of poor oral health? If we look at the European and others, it's around 12% of the people living in the most deprived area, compared to nearly 40% for Pacific populations. And I will wrap it up there and say thank you very much.